So Susan worked in a variety of clinical settings, from cardio, surgical and trauma to A&E, flight nursing and interventional critical care. And she's now the lead Neurocritical Care Nurse Practitioner at the Ohio State University Wexner Medical Center in Columbus, Ohio.
We're going to talk today about both primary and secondary brain injury, as well as talk about the guidelines on how to manage that. We're going to talk a little bit about intracranial pressure and how you manage that, and how do you identify that. So talking about herniation syndromes. All right, so why are we talking about traumatic brain injury? Well, it's the leading cause of death in high-income countries. And then as motor vehicles have been introduced into lower-income countries, there's a sharp increase that's happened globally. The World Health Organization is also projecting that in 2020, traffic crashes will be the third greatest cause of global burden of disease and injury. So there are various mechanisms of injury that can cause traumatic brain injury. So with any trauma patient, it's hard to not go directly to what is obvious. So if someone came in with a drill bit in their head, it's hard not to go directly to what the heck do I do with that drill bit in the head and go directly to that. But it's important to evaluate traumatic brain, or actually any trauma, but traumatic brain injured patients in a systematic way. And the primary assessment is an assessment where it's very quick, it's very pointed, and the purpose of it is to quickly evaluate whether or not there are any life-threatening injuries that are occurring. According to the traumatic brain injury guidelines, we need to think about intubating patients that have a Glasgow Coma scale of less than 8, and we'll refresh everyone about what that Glasgow Coma scale is. It's important to put in a nasogastric tube or a tube to decompress their stomach, or else that cheeseburger or guinea pig if you're in South America, or whatever might come up on your shoes. So you want to prevent people from vomiting and aspirating, and so putting a tube in them to decompress their stomach is very important. With airway and breathing, important things to note is if you're suctioning a patient, pre-oxygenate them, because what can happen is they can, again, desaturate, and that would be bad for the brain. You want to recognize that in someone that has an increased intracranial pressure, it can cause a bump in that pressure. Sometimes, obviously, airway comes first, so you have to clear the airway. So if you need to suction them, go ahead and do that. Limit it to 10 seconds because the stimulation, that time period also helps with the oxygenation piece. Actually, D5 and W can increase cerebral edema. Instead, what you should do is 0.9 or lactated ringers as your primary fluid of resuscitation. But I just want to remind folks, there is no Glasgow Coma scale of 0. If you say that, no one is going to listen to another thing that you have to say, because they're going to think you don't know what you're doing. So the lowest Glasgow Coma scale is 3. And what you also need to do is make sure that you are evaluating the best response. So if you're plegic on one side and following commands on the other, they get points for following commands. Furthermore, if the patient is intubated, even if they're mouthing around the ET tube, they can't speak. So they get a 1, but you put a T next to that, indicating that they have a tube in their throat, not allowing them to speak. There's a nursery rhyme in the United States, I'm not sure if it's global, and it talks about Humpty Dumpty. And Humpty Dumpty is an egg, and he sat on a wall and fell off, and all the king's horses and all the king's men couldn't put Humpty together again. Well, in a primary injury of the brain, that injury happens. We cannot do anything about it except to maybe tell people to wear a helmet so it doesn't happen to begin with. However, we can't do anything with that. With a basilar skull fracture, if it's in the front part, you can get what's called raccoon eyes or periorbital edema. You can get some conjunctival hemorrhage as well. Sometimes it's hard when people have just been beat up in the face to differentiate just that beating from a traumatic brain injury. But if their face looks like that, what has that done to the brain? So you need to think about that. So the primary insult, again, Humpty Dumpty, we can't do anything about it. It's happened, and now we need to deal with the sequelae of that. Secondary injury basically causes a cascade of metabolic situations that happen, a release of cytokines, it can cause inflammation, and if we're unable to stop that, it results in necrosis and then ultimately cell death. So we want to do what we can to minimize this secondary insult that's there. But early signs might be headache, irritability, or even agitation. So patients might get agitated, vomiting, photophobia, or just becoming more lethargic might be the early signs of that. So those are the things that you need to really be thinking about with that. So hyperosmolar therapy is one thing. Unfortunately, there's no level 1, 2, or 3 evidence on what the outcomes, long-term outcomes are, but the guideline committee all felt like there's a universal belief that it is helpful and it should be used. So the guidelines include the use of these osmolar therapies. Also, good to know that your body makes CSF all the time. If you put out more than 20, you need to let someone know, because you may need to clamp that off, because you can actually get a herniation syndrome because you've drained too much of the cerebral spinal fluid. So if you're going to be moving the patient at all, sitting their head up, if they're getting out of the bed, you want to make sure that you clamp that off so you don't overdrain the spinal fluid. Globally, we want to make sure that glucose is within a normal range. That normal range has not really been identified yet, but we don't want them to be hypoglycemic. The brain doesn't store glucose, and so we want to make sure that we keep them, in that maybe 120 to 180 range. Above the 180, start thinking about an insulin drip, because that can cause bad outcomes too. We want to get these people up and moving as quickly as possible, and I just want to mention that patients that have that external ventricular drain, that doesn't mean they have to stay in bed. They can get up, they can get moving. We just have to be careful and clamp things as they're moving and make sure that their pressures aren't too high when we're trying to do that. Also important to know, steroids in brain injury should absolutely 100% not be used. They actually cause worse outcomes, and they don't do anything to help your brain, so not do that.